Hello, everyone. I think we're now live. I'm joining you from the west coast of the U.S. My name is Alison Skalet, and I'm an ocular oncologist at the KCI Institute in Portland, Oregon. And I also do translational uveal melanoma research. And I have the great pleasure today to be here virtually with Dr. Julia Bernier from McGill University, Dr. Sarah Copeland, and hopefully soon Dr. Helen Calerai of the Liverpool Ocular Oncology Research Group, and Dr. Bill Harbour of Bascom Palmer, University of Miami. Please feel free to ask questions in the question and answer chat function. We'd love to take your questions live. And I'll start us off by asking Dr. Bernier, there are many biomarkers that we're looking at for liquid biopsy and uveal melanoma. I'm wondering which do you think is most promising, and when do you think these may be available for clinical use?
Thank you. So I think that's a really great question, and I think it's at the heart of what a lot of us researchers are trying to uncover. I think that the long-winded answer is that the different biomarkers will be appropriate for different scientific and clinical questions that we want to answer. So it's not a competition between ctDNA and circulating tumor cells, but really about when and where it's most appropriate to use different forms of liquid biopsy. I think, for example, detection versus treatment response versus disease progression, we'll be able to utilize different forms of biomarkers using liquid biopsy that can inform clinical decision making. Certainly, it's still in the research phase. We're all working hard. I was very happy to see so many talks on liquid biopsy. Working hard in the ocular melanoma field, but in all cancer fields, to get liquid biopsy to the clinic. A few years ago in 2016, the FDA approved the Roche COBAS testing for non-small cell lung cancer. So it's definitely something that's in the horizon for us to be able to utilize clinically. But I think in uveal melanoma, due to the rarity of the disease, we need to accumulate more data and more samples. And that's why I think it's so encouraging to see so many collaborations coming forward in big centers where there are lots of samples, where we can have more data and bring this to significance. But I think, the short answer is that in the, short to medium term, I think this is something that we'll be able to at least get, to be being used to help in a multifactorial way, help in clinical decision making.
Thank you. So it sounds like we now have Dr. Calerai with us this morning. To Drs. Copeland and Calerai, why do you think that understanding melanocytic embryology is of relevance for uveal melanoma development and spread?
Well, I'll start answering that, and then perhaps Helen may want to chip in. I think it's actually astounding how little we know about normal melanocyte embryology and biology. We know a lot in the skin, and the various factors which cause the migration of melanoblasts into the skin and then up into the epidermis and along the hair follicles. But we don't know what are the factors which are involved in the melanocyte migration into the choroid. And I think if we can better understand that and the whole microenvironment of the normal choroid and the developing choroid, then we can also then understand what happens potentially as the melanocytes de-differentiate and undergo malignant transformation, and then ultimately escape into the bloodstream. And so just perhaps following on from Julia's comment about the circulating tumor cells, it could well be that we're not necessarily looking for the right markers. It could well be that these melanocytes are de-differentiated and they no longer have the mature markers on the outside of the cell. And so we perhaps should be looking more for the immature markers of the sort of melanoblast-like variety of the melanoma cells. So that's the one reason. I think we're trying to address two things: trying to understand or address this gap in our knowledge about just the embryology of the eye, and particularly the embryology of the melanocytes and blasts within the uvea, and also, these features play a role in the spread of the melanoma cells once they become malignant? Don't know whether Helen would like to say anything more to that, if she's there.
Here she is. Unfortunately, the audio doesn't seem to be working at the moment, Helen. So, Dr. Copeland, I think you really hit the nail on the head here in terms of the unusual dedifferentiation or sort of stem cell-like phenotype that we see in more advanced uveal melanoma cells, and how that is very challenging when we're looking at circulating tumor cells and trying to identify these populations. I know that this is something we've certainly been working on in our lab. And we're finding it much more challenging than looking at other sort of carcinoma type of cancers. I don't know if Dr. Bernier has any insight into this topic. Is this something you're working on as well? You may be muted.
Yes, hi. So everything cut off for a little bit, so I unfortunately did not hear the question.
So we were talking about how as uveal melanomas mature and become more dedifferentiated as they evolve, some of the melanocytic markers that we're typically looking for that can be used to identify cells are lost, and that this is a particular challenge in looking at circulating tumor cells in this cancer as compared to with other cancers, like pancreatic cancer, for example. This is something that we've been struggling with in our lab, trying to figure out how do we identify the full population of these cells to analyze them. Do you have any insights into this? Is this because you work in multiple cancer types? What are your thoughts?
Yeah, I think that's a great question and an issue that pops up in the liquid biopsy field in general. Across tumor types, we see that the ability to differentiate circulating tumor cells from other cells of the body is reliant on, as you're suggesting, a bit of a flawed system, because we're reliant on markers that may be lost during, for example, tumor progression, metastasis, and we do see this in other tumor types as well. We're not looking so much at circulating tumor cells, but we also see this issue, for example, when we're looking at extracellular vesicles, where we rely on vesicular protein expressions that we cannot be sure isn't lost. So we might be selecting for a specific, for example, vesicle population that is not overly representative of the tumor cell population. But I think these issues with being able to differentiate what is stemming from the tumor and dynamically monitoring those genetic and protein expression changes is really important. And that's why Dr. Copeland's work on the biology of these cells and is so important and will inform on a lot of our liquid biopsy experiments.
Right, and I think, oh, sorry, go ahead.
You know, one factor that we also need to consider here, and I first started thinking about this when Dr. Bernier's father published a paper about 20 years ago where they looked using PCR at markers for melanoma cells in the blood. And the surprising thing wasn't that they could find these markers, but the fact that everybody had these markers. Everybody with uveal melanoma, even those who never metastasized, had these markers in their blood. And I think that's been corroborated over and over again, that we can find circulating tumor cells in patients who never develop metastatic disease, who have class 1 low-risk tumors. And so I think and I think Alison, some of your own work corroborates this. But I think what that tells me is that access to the bloodstream is not really the rate-limiting step in metastasis in uveal melanoma. The cells that metastasize successfully, it's already sort of written in stone in the primary tumor from their genetics. You know, based on the mutations that they have and so forth. so that, we have to sort of factor that in. How does the circulating markers, how are they going to be useful? Are they going to be useful in telling us who's going to metastasize, or are they useful in sort of giving us a response to therapy? Is that where they're going to be most useful? But this idea that you can use it as a prognostic test, who's going to metastasize and who's not, is not going to be that simple.
No, I agree with the comment. I think the choroid is one of the most vascular tissues in the body, and it's not surprising that whatever choroidal melanoma develops there, the tumor cells are going to escape into the blood. So whether it's low or high risk metastasizing melanoma, these cells are probably circulating. It's whether they are able to survive within the systemic circulation and then ultimately survive, creating a colony, inverted commas, within the liver. And so that, I guess that's the thing. It's trying to work out how valuable is that information regarding the circulating free DNA or circulating tumor cells, and then how, if they are present in high-risk patients, how aggressive is one then to be in giving any therapy to the patient?
Yeah, and if you look at the most important risk factor for metastasis is having loss of BAP1, and yet if you look at BAP1 in cell culture models or in the research lab, it does losing BAP1 does not make the cells more proliferative or invasive or anything like that, but it seems to be helping them to escape the immune system. So it seems that really the immune system is playing a very important role here that we don't fully understand yet.
So that's a great segue into the question I had wanted to ask you, Dr. Harber. You've shared some really fascinating work looking at the evolution of the tumor microenvironment in these tumors. I think one of the biggest questions is, how does immune surveillance presumably break down and drive the development of clinically apparent metastasis? Does your work provide insight into what may be going on in these high risk versus low risk tumors to cause clinically important metastatic disease?
Yeah, well, we've known for years that, if you look just at tissue sections from uveal melanomas that have a high risk for metastasis, those that we now know have BAP1 mutations for the most part, they have a lot of immune cells in there. There are a lot of lymphocytes, white cells, T cells, B cells, and there are a lot of macrophages, the garbage removal immune cells. So it's sort of like, why are they there? There are actually more of them there in the bad tumors, but they're not doing anything. They're not inactivating the tumor. And the work that we just published earlier this year kind of helps get a little closer to an insight into that, in that these lymphocytes, these white cells, these macrophages, they're dysfunctional. They're there, but they are inhibited or inactivated. And at least one way that they seem to be inactivated is through upregulation of a protein called LAG3. In cutaneous melanoma, something similar happens, but the proteins that mediate that are called PD-1 and CTLA-4. In uveal melanoma, at best, we get a 10% response rate by inhibiting those proteins. But the reason we think now is that those proteins are not really highly expressed in uveal melanoma. It seems to be other immune checkpoint molecules that are important. But I suspect that it's not just that. I suspect that the macrophages are also driven into a non-active state or an altered state where they're not functioning properly either. So the tumor seems to be, going back to the embryology and the normal biology, I don't think that melanomas or any other cancer, they don't invent new things to survive. They basically reactivate normal mechanisms that are occurring in our bodies, and they use them in bad ways to help them survive. And so I think the tumors are using these immune mechanisms that normally protect us, but they're using them to shut off our immune system so that it can't attack the tumor.
Perhaps if you don't mind, if am I allowed to follow up on that? I think our way to understand uveal melanoma and the metastases is really to concentrate on the microenvironment in the liver, and I think we and others have been able to demonstrate that it is probably that the macrophages, particularly the M2 macrophages, are creating this immune suppressive environment within the metastases nodules, and it seems in a way an active process. They're actively supporting the growth of the tumor cells, and that combined together with the hepatic stellate cells, which are activated within the liver and producing sort of this thick stroma or collagen sort of fortification almost within and surrounding the tumor nodules, then they're blocking out the artillery, so to say, the artillery of the lymphocytes, which are predominantly out with these metastatic nodules. And as Bill said, they're almost paralyzed. They're ineffective in destroying the tumor cells. If we were to mix those T lymphocytes, which are outside the metastases, and put them in a culture dish and mix them with the melanoma cells, they wouldn't be able to kill them as they normally should. They've become exhausted, is the term that's given, and so they're really ineffective. So this is unfortunately probably one of the reasons why the immunotherapies, which are quite successful with metastatic skin melanoma, aren't as successful with metastatic uveal melanoma to the liver. That is, there are these anecdotal cases where the immunotherapies do work in metastatic uveal melanoma when the metastases occur in other sites, in other organs, such as, very strangely, the metastases may occur in the skin, and those metastases respond, whereas those within the liver tend not to.
Yeah, I think for this audience, I think for patients, I think the take-home message is that we were told 5 or 10 years ago that immunotherapy is helpless for uveal melanoma because it doesn't have enough mutations the way skin melanoma or lung cancer has, so it's a hopeless thing. And I think the take-home message is that's not true. We can make progress in immunotherapy. We just have to understand better what this cancer type is doing to undermine our immune response.
Yeah, agree.
And if I could add, I think that's Dr. Harber's point is at the heart of personalizing our care based on particular patient characteristics and patient groups. And I think this is to show that one therapy might work for one person, not for another. And all the work that we're doing in basic science and the work of Dr. Coupland and Dr. Harber and groups all around the world is really, I think, to better understand the disease so that we can identify which patients might benefit from particular therapies and which patients might benefit from particular monitoring, for example, by biomarkers, the work of Dr. Skalet as well. So I think that's where the exciting next few years will be, to better understanding the disease so that we can apply that knowledge in the clinical context.
Helen, do you have any comments? Unfortunately, it seems her audios may still not be working. So one of the things I thought was very interesting in your single cell sequencing data, Dr. Harber, is the case of the indolent, I think it was a class 1B metastasis, in which there were plasma cells, so B cells that secrete antibodies in that tumor microenvironment, and that perhaps that was a reason that tumor, although metastatic, was not as aggressive. Do you think that may be a conserved feature? We know that some patients with metastasis progress very rapidly, and others have a more slow course of progression. And what are your thoughts on the mechanism for that?
Yeah, so I think, it's just one case, so it's hard to you have to be careful not to over-interpret. But I think that, and that case was very interesting in that the patient metastasized 20 years later to the lung, 20 years after the initial treatment, and then that lung metastasis was removed. And she went another 10 years before she developed a metastasis in the liver. So this is extremely unusual. We've all heard of these cases and we write them up, but they're unusual. But yes, when you look at the single cell level, the tumor in the liver was loaded down with immune cells called B cells, or plasma cells, which are derived from B cells. And so this goes along with what we're talking about, that the class 1 tumors that have a lower rate of metastasis, when they do metastasize, they tend to be less aggressive and more indolent. And, I think you could extend that back to say, the tumors that don't metastasize more, I think that many of them, it's not that they never got into the bloodstream, is that the immune system successfully controlled them. So this is an insight. It's just one case, but it does suggest that hypothesis might be right, that if we can rev people's immune system up to recognize the tumor, that's our best bet in improving survival.
We have, I think, an excellent couple of questions from the audience. The first I wanted to address is, can a patient with irradiated choroidal melanoma receive a medication to kill off circulatory tumor cells in the bloodstream before they spread to the liver? So this is something that we call adjuvant treatment. It's an area that Dr. Harbour was discussing. I think it's a very important question. And so I open this up to the panel. Where are we with adjuvant therapies for this disease?
I mean, I think if you just kind of work your way back from overt advanced metastatic disease to catching disease early, patients live longer if we're able to intervene earlier. So I think adjuvant therapy is the natural progression backwards to, the patients at high risk because of their genetics. They have a class 2 expression profile, for example, they're at a higher risk. Not waiting for the metastatic disease to develop, but assuming that they already have microscopic disease in their liver and possibly elsewhere. So, traditionally in oncology, you only treat people in the adjuvant setting with a compound or a drug that's been shown to work in the metastatic setting. Unfortunately, we don't really have anything that works that well in the metastatic setting yet. We're getting better. But we also don't want to make people really sick in the adjuvant setting. Some of the drugs that work the best, like Immunocore, the GP100, that's shown a lot of promise. It only works it's only applicable to a certain subset of patients, and it can make them quite sick. So the challenge with adjuvant therapy is something oral, preferably. You're not having to go in for an infusion, something that's well tolerated. So that's a real challenge. But with that in mind, we and others have identified targets that may or may not work in the metastatic setting, because in that setting, you're having to kill many, many tumor cells. But in the adjuvant setting, maybe all you have to do is put them to sleep. You may not have to kill all the tumor cells. So that's really a focus of our research, is to try to develop drugs in the adjuvant setting that would be well tolerated, that are not very toxic. So there is a lot of one of the things that I mentioned in the talk was about an HDAC inhibitor. We've known about HDAC inhibitors for about a decade, but we're closing in on the more specific HDAC inhibitors that may be most effective in this setting. And there's certainly other drugs that are being tried. So this is an increasing area of interest, this adjuvant therapy.
I think we have time for just one more question. So another excellent audience question is about identification of those rare class 1A patients who do go on to develop metastases. How can we better figure out which patients appear to be low risk based on prognostic testing, but actually will go on to progressive disease?
The two things. One is, and now that we're doing really deep mutational sequencing, we find that occasionally you'll find a class 1A patient who has a very small subclone of BAP1 mutant cells, and those might be the ones that are actually getting out of the tumor. So we need to combine gene expression profiling with deep sequencing for mutations. The other thing is, I think there are occasionally just class 1A patients with no high-risk mutations that can metastasize because of weaknesses in their immune system. So we're actively trying to pursue these cases to understand what went wrong with their immune system that we can learn from.
Perhaps I can add to that if we've still got time.
Yeah.
I think metastatic risk is probably not all about genetics. I think we also have to consider, as Julia was saying, personalized medicine encompasses holistic features such as age and gender of patient, location of the tumor, size of the tumor, and in addition the genetic status of the tumor cells. And as Bill mentioned, we have greater understanding about the mutational status of the tumor cells, and we have improved technology for prognostication. So we have the bespoke next generation sequencing panels where you can look at BAP1, you can look at SF3B1 and the other mutations, and it could well be that these class 1A tumors have additional mutations or mutations such as SF3B1, which may result in metastases occurring, but at a later stage.
Thank you so much. I really appreciate this discussion with these fantastic panelists. I look forward to seeing more of your work, as I know the rest of the audience does. Thank you so much to everyone who joined us live. It's really been a pleasure to be virtually with you, and looking forward to being with you in person in the future. Please do stay tuned. The next session is going to be great. It's a live session entitled Vision, a Patient-Reported Registry. That's going to be at 12:30 with Drs. Marlena Orloff, Rich Carvajal, and the Cure OM co-founder, Dr. Sarah Celllike. Thank you so much for your time.
Thank you very much. Bye then. Bye.